Being recorded.
Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. Next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on March 5th, 2023. Is that 2024? Correction? March 5th, 2024.
So moved.
Hold it a second. Motion and moved. Second poll, I'll poll each member for his or her vote. Dr.
Yes.
Katz,
Yes.
Yes.
Dr. Pagan,
Yes.
Jackie Rowe Adams.
Yes.
That's it?
Yep.
Okay. Thank you. Uh, Motion has passed. Next is a diversity and inclusion update from Ivelisse Mendez Justiniano.
Thank you, Dr. Martone. So today we will be presenting on the system-wide accomplishments from the period of January through May. And then it will be followed by an update on our Equity and Access Council, the Monitoring and Evaluation Work Group. We're going to start off with a snapshot of our top training breakdowns, our top sessions. And this is again from January 1st to current day. And this is a snapshot in time where we see that our top learning right now is identifying and managing unconscious bias. This is an e-learning that is being made available to all staff, and it's being marketed accordingly. This is being followed by religion as a social determinant of health, and this is a workshop that's available to staff with a total of 268 completions, followed by a panel that we held in honor of Women's History Month, which was attended by 205 staff. We also celebrated Black History Month with a panel titled Keeping It Alive, which was attended by 176 participants. And lastly, Building Psychological Safety in the DEI environment, which is attended by 87 individuals. All of these trainings are ongoing and will be repeated. We are introducing a interactive workshop, and so this is a different model for teaching individuals, and we will be presenting on that in the next session. In terms of system level achievements when it comes to language access, we have completed the RFP for interpretation services update. Our new interpretation contracts were approved by the CRC on April 16th. We will be presenting to the MMPA board in June. And the new contracts will cover the following services. And this is an effort to standardize and streamline services on language access throughout the system. So we are covering over the phone and video remote interpretation, on-site interpretation for spoken languages, on-site interpretation for sign language, and language proficiency and interpreter skills assessment. So the provision of language services will be provided in person, via phone, and via video. Moving forward, in terms of one of the new introductions that we've been working on in the DEI office in terms of veteran support, we had a pilot that was launched in Metropolitan Hospital on March 8th. And what we do is we partner with the Mayor's Office of Veterans Affairs. Our goal is to visit each acute care hospital in 2024. We just held a session in Woodhall on May 3rd. And what we've done is we've opened the sessions not only to our employees, but the communities and the patients that we serve. So if you happen to be a veteran, we have on-site staff that's helping you to start a VA claim, update military records, obtain copies of your military records, appeal VA decisions, and learn about services and more. And just to highlight some of the accomplishments within that field is that employees that have come to us that have been out of military service for about 10, 15 years didn't realize that they can still apply for benefits. And this can make a difference of hundreds of dollars in their pockets on a monthly basis, in addition to benefits and other benefits such as burial benefits, nursing home benefits, things that can be life-changing for them and their family. I am also happy to announce that as of this morning, we received HEA, the Healthcare Equality Index designation for all 11 acute care hospitals, which basically designates our hospitals as LGBTQ healthcare equality leaders from the Human Rights Campaign Foundation. In addition to each 11 of our 11 hospitals, we have 7 of our Gotham sites which also received the designation. These include Belvis, Cumberland, East New York, Gouverneur, and Morrisania. And I just want to say that this is also consistently since 2015 to present that we have earned this designation. So it occurs every other year. One year we have the health equity for our acute care hospitals. This year we will start working on the long-term equality index. So
Very good.
good news for the system. In addition to that, keeping on and improving on our LGBTQ plus services, we also partnered up with the Institute for Human Identity, where we provided mental health training, which is an advanced clinical training program for the system's mental health professionals. And this is really aimed at building their clinical knowledge and affirming therapy specifically to our LGBTQ patient population. For this particular, in the onset, we have 22 members of our staff who completed it. It's 18 hours, and it's a 3-month training pilot. Because it has been so successfully received and the feedback has been so good, we are going to be extending this program and making it available for other clinicians. And lastly, in terms of events and presentations, for Women's History Month, we hosted a Women Mentors in the Workplace program featuring female leaders from the system. In addition to that, our Gotham Center Gouverneur celebrated Holi by enjoying colored powders, festive dances, and quality time together. And you see a picture featured there. And then we had 2 staff members, myself, and I was joined by Slevana, our CEO from South Brooklyn. We were speakers for the Becker's Annual International Health Conference in Chicago on April 8th. And lastly, on April 11th, we joined with Herc Leadership. We had the Sheikh Pastor Guilford Monrose and Musa Drameth, as well as our community advocates, Abu Si Diaki, celebrated Eid by celebrating a feast to guests at the Randall's Island Humanitarian Center. And that concludes my report.
Thank you. Any comments, Dr. Pagan?
Yes, on the VA, great work
Yes.
on the VA. And I was wondering if you had any data or next time maybe present some data on how many veterans or you were able to serve or maybe collected.
Absolutely. So we are collecting the data. Right now, what I have is narratives that I have received from the veterans themselves. And our employees have stated they feel seen, they feel valued, and they're very excited, and they're going to let other individuals know. Right now, we're reaching out to the veterans. Veterans self-identify for New York City Health and Hospitals, right? It's not something that we know exactly who. If you choose not to self-identify, we don't know. So what we've done is we've specifically reached out to those that have self-identified, but in addition to that, we've partnered with each of the public affairs officers at each of the hospital facilities. We've created posters, we've had a massive LinkedIn campaign and social media to get the word out. And so now what we want to do is, now that we really focus on our employees, extend that to the patients and extend that to the community. So we're excited about that. Thank you.
Dr. Katz?
No questions.
Jackie Rowe Adams?
I think it's wonderful. Was that Pastor Monroe in your picture?
If we go back
No, right there.
from the community, yes.
Yeah, he's very active. I was with him 2 weeks ago. So I'm glad to see. So you're really heavily involved, and keep up the good work.
Thank you. We also just hired another community liaison, so we will be increasing our work with the community and attracting other patients and to the services that we provide.
Excellent. Yeah.
Thank you.
you.
Yes. Next is an update from the Equity and Access Council, Natalia Seniz and Nicola Davis.
Hi, good afternoon, everyone. Natalia could not be here today, so I'm just going to introduce our speaker. We have Komal Bajaj, who is our co-chair for the for the Monitoring and Evaluation Work Group, who will be presenting our update today. So, Komal?
Thank you very much, Dr. Davis. My name is Komal. I'm the Chief Quality Officer for Jacobin NCB, and I'm thrilled to be able to present to you some of our work around monitoring and evaluation as it relates to health equity. Next slide, please. One more, please. One more. So, this work really has been informed by many perspectives, including our data and analytics team, our pop health teams, as well as our quality and safety team. Um, the Institute for Healthcare Improvement released a framework for healthcare organizations to improve health equity. And one of the components that they focus on is building infrastructure to support health equity. We took this as an opportunity to really look at our existing data infrastructure. As part of their strategy, they suggest that we provide staff training and support regarding real data collection, really articulate the reasons to both our staff and patients to collect real data, as well as over time really begin to look at the completeness and accuracy of our real data. Next slide. And so, the dimensions of data really are, is it accurate? Is it complete? Is it updated regularly? And is it consistent with, sort of our best practices around data collection? Next slide, please. So we've had quite a robust, sort of road so far, and lots of effort and energy in improving our structures for, patient-centered approaches to real and other data collection. In 2021, we updated our collection fields according to the OMB categories. We standardized our ethnic groups, as specifically as it relates to Hispanic Latinx or non-Hispanic Latinx. And we included a hard stop to collect this data within our EHR. We also, in line with trends, expanded our ethnic background from 20 categories to 200. There was a lot of energy to ratify the enterprise definition in 2021. And once that ratification took place, both the Office of Population Health and DNA began utilizing those standard groupings. So we were all sort of talking the same and rolling up data the same way. We continue to promote person-centered approaches to data collection through the implementation of kiosks, as well as MyChart. And as of a few months ago, the end of March, we incorporated the Middle Eastern OMB grouping. Again, sort of as things evolve, we continue to evolve. And so our goal, continues to remain to stratify quality measures by both complete and accurate data collection. And so, here is a snapshot of, something that has been presented before to this group, which is this is an example of our Pop Health, one of our Pop Health dashboards, which is looking at blood pressure control. And clearly, as we look at variation, we are able to then, understand more about that variation and then deliver more targeted solutions to address gaps in care. And so, what are our next steps? Next slide, please. As it relates to assessing both completeness and accuracy. So, because of some of the hard stops and because of some of the other patient-centered approaches that we have, certainly our completion has gone up substantially, and we'll show you that. Some of the ways that we're looking at completion are, also then looking to stratify that by populations or specific facilities where we will be able to identify hotspots of missing data, which I'm happy to report are now very few. So if you take a look, next slide.
Let me ask,
Yep.
just interrupt for a second.
Absolutely.
Because Sally raised this yesterday. We were looking at some data from one of the Gotham sites where there was a very high percentage of missing data. It was like 60%. And I was wondering, is the way that we collect racial ethnic data different in the outpatient sector than in the when people are hospitalized?
It shouldn't be, because we're using the same sort of EHR, but certainly the flows as to who's collecting it, will vary broadly, even across different ambulatory sites. I would love to, as we look at those hotspots, I'd love to understand a little bit more about, is it just not there? Or is it, checked off as something else, or, prefer not to answer?
It was not there.
Okay.
But I'm guessing that it's what you're saying about who is recording it. That perhaps because there's a more formal hospital intake procedure, more so than a clinic visit. I mean, I'm trying to think, even in a clinic visit, I'm looking at Nicole since she also works in the outpatient center. I'm not even like sure if a person doesn't put it in themselves. I don't think on an outpatient basis anybody would. But I think on an inpatient basis, somebody would on intake.
No, I think the registration staff will put it in. The question is, they don't necessarily ask the patient. They might just put it in based on how the patient looks to them.
Yes.
But they will document it, and I believe it. I know we've played around with whether or not it's a hard stop for the frontline staff. I think it might be for registration staff a hard stop, but
I would love to know a little bit more specifically about what data you were looking at, and also like how often are those patients seen? Like, did we just sort of miss?
Yeah, Ted presented the data. I can't remember. Do you remember which Gotham it was? It was because they were going for a new
It's the one in Williamsburg.
Williamsburg. The Williamsburg Gotham, and it was like 62% was unknown.
That is very important to know. And in fact, as we go through this over the next couple of quarters, we will be able to have clarity on that. And to be able to, I think, answer your question a little bit about what is the flow in outpatient? Does it vary by site? And what is the flow in inpatient? And how can we sort of synergize the two if there are any opportunities? So that's an
I'm also trying to decide how I feel. I mean, obviously what you want is for patients to identify themselves. I'm trying to decide, to the extent that the patient hasn't done it and the registration person does it based on how they appear, is that worse than no information, or is it better than no information? I'm not sure I know the answer to that.
I'm not. Well, we want to get to the ideal.
Right.
And I think what you're going to see is how we're planning on just validating the data that we have, so we know how much of a mismatch there actually is in terms of how a patient would describe themselves versus what's in the chart. But we don't want registration staff to just be going according to how a patient looks, because
Understood.
they're going to they're likely to misclassify versus how a patient would self.
No, definitely, it's the best. I think you're going to have to decide whether in a future iteration you're saying you may not, as opposed to what probably is going on now. Yeah. And again, you'll have to take into account that that probably the registration people are right 80% of the time. And so you're going to lose data that's probably 80% correct in favor of no data. And again, that's why I say I'm not sure. It's clear what's ideal. What's less clear to me is, if they characterize every Spanish speaker as Latina, they're not going to be far off, right? A relatively easy determination to make, in the sense of because of the language the person is speaking to them in, when they're speaking Spanish. That's why I'm just not sure, whether I get the ideal. I'm just not sure from a practical point what we do about it when the registration person is the person making the box.
Right, and I think that we do some of those changes in the back end. For example, if ethnicity is missing, but their language is Spanish, then we do coding on the back end to code that person as Hispanic.
Right.
So there are some things that we do on the back end that helps to not have so much missing data. But I can certainly talk to Ted to find out about Williamsburg and where he got the data from for there, because I don't think in any of our data sets I've seen that high rate of missingness. So we can look.
Yeah, I hope that as we do our process, we find that same flag, right? And we'll triangulate that. And I think you bring up a really important point. Overall, right, you can see from these pie charts here that our unknown and something else sort of has gone down. But clearly there's going to be a wide variation depending on site. And so we'll have some more sort of granular action plans based on these analyses as we move forward. Next slide, please. To that point that Dr. Davis was just making about consistency, we, as part of the ratification, did also make some agreements about some of the back end to sort of promote, roll up. But you can see here, right, if someone is listed as non-Hispanic, Latinx, and they're listed as Asian, and their ethnic background is Chinese, great, check. But sometimes what we'll find is someone is listed as, say, Hispanic, and their preferred language is Mandarin, right? And so it's those, discrepancies that make us want to look a little bit deeper on sort of that process of collection. Because it's filled out, it'll look like it's complete, but clearly there's some consistency gaps here. And so we'll be able to have sort of a percentages of this sort of discordance in different flavors. So to the point of your question, Dr. Katz, and your comment on what is worse, right? Part of this is understanding the accuracy of our data. And so again, the IHI guidelines suggest sort of validation sampling as a way of ensuring that what we think is self-reported is truly self-reported, and that our EHR does represent sort of a patient's identity. And so we are in the process through population health developing sort of research methodology to be able to do that. So, capture patients where they are and ask them just a few simple questions to make sure that what is in our EHR is indeed that. And when it is not, ensuring that it's rectified. And then as a result, we'll have an understanding of what percentage we think is inaccurate.
So when I go in and look at my chart, it asks me at the top, update, right? Update information.
Yes, it does.
I wonder if there's a way of like forcing me to actually see the question and say, and then validate it, things like that.
Yeah.
Where I've seen publishers do this in academia, where they keep bugging you with the same question.
That's right.
Until you answer it.
Right.
But how do you do it in a way that is okay? You don't want to provide the information. That's okay, but give people choices to provide the information.
Dr. Bagan, I think what you're describing is absolutely going to be one of the sort of strategies, but I think having a little bit more clarity on who we need to target. It would be interesting actually to look at incompleteness or inaccuracy and MyChart access and how that sort of relates to each other, if at all.
And I think the way we deal with the sensitivity question is that we want you, the goal would be to force people to answer the question, but one of the choices has to be, I don't want to answer your question.
Yes.
Right, so you have to answer the question, but you can answer the question by saying, I don't want to tell you.
Yeah.
Right, right, yes, we have a box. It says, don't wish to disclose.
Right.
And that should be a valid answer, is that, right, we want you to answer the question, but you're allowed to answer it by saying, I don't want to answer your question.
That's right.
Okay, good.
Yeah, and that'll satisfy our completeness and accuracy.
Yes, it's
Right?
complete, it's
Yeah,
accurate.
that's
They don't
right.
want to answer your question.
And it's something in that space. That's
Other organizations, other health systems have had some either patient-facing campaigns, we ask because we care kind of concepts. To your point, the sensitivity, we want people to answer it, but part of it is understanding,
Why do we want the data? Yeah.
Right.
It is hard for people to understand because you're not generally asking them for their health. You're asking them to answer a population health, and that's a foreign concept to most people not in, right. The natural assumption is you're here to see a provider for your health, and it's therefore not clear to most people why you would care what their ethnic or racial background is.
Definitely, and even for those that are mostly asking, our staff, right, like they might not also really have understanding of sort of why it matters. It's a box to check, it's another thing to do, right? So we will have some interesting insights and hopefully some clear action plans to discuss with this group, as we move into the rest of 2024. And similarly, just as we went through the exercise of really thinking about these definitions, I'd like to extend that sort of standardized groupings to some of the additional demographic elements as well. As you can see listed there. So much work ahead of us. Really have to commend the DNA team and the pop health teams. They're really a lot smarter at all of this, sort of how it's built and how, some of the impediments. It's been interesting to see the iterations over time.
So one example of a few years back, I was involved in a study where we had very high response rates to a survey, and I was like, wow, how did you do that? And it was a survey in Spanish, and I asked the person that was running the survey firm, and she told me that it was that they would just convey to the person answering the survey that this was important for the community. And I thought that stuck to my mind in some ways, that somehow some communities respond more than others to information like that. So anyway,
Yeah, that's interesting.
Yeah.
Like a collective responsibility.
yeah, like a collective, let's
Yeah.
help each other, that kind of
Yeah.
language. But
Thank you.
So look forward to your feedback. Thank you.
Any other comments, Dr. Katz? Jackie Rowan?
Yes, I wanted to go back to the proxy. So the proxy is when the patient is not able to speak or say for themselves, you deal with them doing a proxy, sending it in. How do that work?
Yeah. I imagine it would be similar to how we asked all kinds of information for that individual. I think I'd have to get back to you specifically related to this process. I don't know if you have any thoughts.
Yeah, no, I mean, I think, I agree. I mean, I think it would be the same way we would ask about other types of information. Whoever is answering on behalf of that patient, they would probably be asked this information as well.
But the patient have to sign that proxy.
Yeah, but that's
Give them
usually-
permission. Okay, so that's me. So I'm not able to come in. So usually a proxy, if you're not able to come in, a proxy is accepted. So I think that's, well, I don't know,
No, I mean, I think usually when we have someone speaking on behalf of the patient, it's
Okay.
usually because the patient is unable to, not just that they can't come in, but maybe they're too
Unable,
sick or
yeah.
they're on a ventilator or they can't communicate for whatever reason effectively. And that's usually why there would be a proxy for that person. And and there's sometimes that person was already predetermined, like their healthcare proxy. That could be someone that was already pre-decided that they would make decisions on behalf of that person, or maybe it's the
No,
parent.
that's what I figured, but I want to
Right.
hear you say it.
Yeah.
Okay.
Yeah.
So, yeah, good. Okay.
Very good.
Thank you. Thank you so much for your report. Thanks. Okay, any old business?
No.
Any new business? No? There being no further discussion, meeting adjourned. Thank you.